Hello, everyone. So we're building upon these different approaches to robotic aortic valve replacement to now approach a more complicated patient. This patient presented with triple valve disease along with atrial fibrillation. So join us on how we approach this robotically.
The right lateral transaxillary approach for robotic cardiac surgery might serve as a platform for extending these procedures to envelop all of cardiac surgery. So to illustrate this, we'd like to present a case of robotic aortic valve replacement, mitral valve replacement, tricuspid valve repair, and biatrial Cox-Maze along with closure of an atrial septal defect in an unfortunate 76-year-old woman who presented with a history of persistent atrial fibrillation on oral anticoagulation status post dual chamber pacemaker, who was living independently up until her admission, but presented with a history of chronic kidney disease and recalcitrant heart failure with AFib with rapid ventricular response, pulmonary hypertension, and presented with cardiogenic shock. She required a temporizing balloon valvuloplasty of her mitral valve and cardioversion. She was able to be weaned from some catecholamine support, but required continuous renal replacement therapy to stabilize her heart failure. In discussion with the patient and her family, palliation was an option as her predicted risk of operative mortality by STS criteria was 50%. But the patient and family wished to proceed, and we elected to proceed with high-risk robotic approach as the patient refused sternotomy. So here we have a look at the echo, and we can see that the patient has significant mitral stenosis of rheumatic origin, degenerative calcific disease, aortic insufficiency that was mixed stenosis and regurgitation, and severe tricuspid insufficiency. Through the same platform, aortic cross-clamping was performed. Antegrade protection was possible with some anterior compression to achieve quadriplegic arrest. So we proceeded with expediency, building upon all of the other things we've discussed so far in the series. This patient had severe calcific disease. The mitral valve was approached and leaflets are excised. The posterior cord groups were preserved, but the anterior were removed. This was done fairly expeditiously to minimize the burden of cardiopulmonary bypass in the setting of her pressor requirements and renal failure. Though her ventricular function was only approximately 50%, there was potential for recovery. So we performed first the resection of the leaflets, followed by the Cox-Maze procedure, as we've outlined before, with the epicardial coronary sinus lesion, endocardial box lesion with the inferior line extending into the appendage, and the superior line followed by the mitral line. This was then followed by the vertical atriotomy, as we've demonstrated before, with the tricuspid completion line, the line to the superior vena cava, as well as to the right atrial appendage, being careful not to jail the right atrial lead, followed by the IVC line, Now at this juncture, I elected to open the aorta due to the presence of aortic insufficiency that was significant, but enough to get initial cardioplegic arrest and complete cardioplegic arrest with corneosteal protection. We proceeded with closure of the left atrial appendage, as we've demonstrated before, through a obliteration technique, enveloping the body of the left atrial appendage, and now proceeding with this two-layer left atrial appendage obliteration and plication of the left atrium. This is then followed by mitral valve replacement, again, enveloping the anterior leaflet tissue for the anterior annulus without pledgets. by everting the tissue and performing a circumferential approach to the sutures from the ventricular side to enable as large of a size as possible. Here's the atrial septal defect created from the balloon valvuloplasty. This is fairly simply repaired with a running 4-0 monofilament suture. And then completion of the mitral valve replacement with placement of the sutures and sized to a 27 bioprosthesis, which was then secured. The vent was placed across the valve, and we then approached the tricuspid. Given the presence of the leads and the expediency, even though we attempt to perform rigid ring annuloplasty whenever possible, from a judgment perspective and expediency, I elected to utilize the suture annuloplasty de Vega method in this case, with good anchoring. Remembering from previous demonstrations in this series, these have to be fairly deep bites, and in order to get good coaptation of the leaflets and durability, this is held and tested and secured. The right atrium was then closed in a similar 2-layer method as previously illustrated. Again, this type of expediency requires excellent teamwork and orchestration, as you can see. Requires concentration from our tableside surgeon, Dr. Wei in this case, who's done an excellent job as we've now started the approach to the aortic valve after placement of that retraction suture on the right atrium to expose the root. And here we are excising these degenerative leaflets. Now, there's not extensive calcium as we've shown earlier in some of the other cases, but there was enough damage that we do need to get good debridement of the annulus. And here's the completion suture line. This was a 23 bioprosthesis, which we felt was adequate in this patient in her state. Suture fastening is performed. You can see no evidence of outflow tract, the mitral prosthesis properly positioned, and closure of the aortotomy. Final testing, and then followed by closure of the left atrium in the standard methods we've outlined using this vertical mattress technique. And following closure of the left atrium, the patient was reanimated, weaned from cardiopulmonary bypass with care, of course. She was kept on inotropic support. Here's her echo postoperatively with no residual mitral or aortic insufficiency, good function, and no residual tricuspid insufficiency, and minimal to no gradient. The patient was then recovered in the intensive care unit and was able, over the course of 6 days, to be weaned from CRRT to her native function. And this is an image of her with her permission, seen 6 weeks postoperatively on simply oral diuretics and antihypertensives, doing very well in New York Heart Association Class 1. She is seen recently on her 1-year follow-up visit and is continuing to do well with normal ventricular function and valvular function in Class 1 symptoms. So this illustrates that through coordinated efforts and accumulating all of the different techniques utilized in robotic cardiac surgery through this transaxillary platform, that multiple valve surgery is possible.
Now we've seen how to do even a triple valve operation robotically. As we build upon all of these experiences, we would submit that this transaxillary approach is a platform for all of heart surgery. So join us in our next episode where we're going to talk about another first, even when we incorporate adult congenital pathology.